Welcome back, everybody. So now we're going to hear from two young investigators. So the first will be Sonja Swanson, who's an assistant professor in the Department of Epidemiology at the Erasmus Medical Center in Rotterdam, the Netherlands. She also holds an adjunct affiliation with us at the Harvard Chan School of Public Health. A lot of her work is on estimating causal effects in epidemiology, so a little bit of a continuation of this theme, but in the particular domain of neuropsychiatric disorders and related health outcomes, and has a particular interest in prevention and treatment strategies. And so she's going to talk about biological and social processes underlying mental health and how epidemiologists can help articulate patient-centered questions and combine appropriate data and analyses to try to answer them. And then we'll hear from John Jackson, who's assistant professor who holds a dual appointment in epidemiology and mental health at Johns Hopkins. His methods research focuses on identifying, refining, and evaluating interventions to eliminate health and healthcare disparities, and developing methods to improve the transparency and conduct of occupational studies and post hoc analyses of clinical trials. That's after the clinical trial is done, and you go back and you mine it for data that wasn't necessarily the focus of the randomized intervention. His work focuses on understanding and reducing the excess morbidity and mortality in patients with mental illness, using state-of-the-art methods to provide insight about effectiveness of potential interventions. And today's talk will focus, I think, in particular on reducing health disparities in this domain. Yeah, and I'll leave it at that. Why don't you guys come on up? Or actually,
Great. So thank you so much for having me here. I'm thrilled to be part of this event, and I just want to thank the Radcliffe Institute in particular for hosting not just today's event, but this entire series. So as Janet mentioned, I'm going to be talking about the epidemiology of neurological and psychiatric disorders. And I wanted to start with just kind of going through what I see as the big questions in this field. And these are probably not unlike the big questions in any sort of subfield of epidemiology. So we want to know how many people suffer from dementia. Who is at highest risk of bipolar disorder? How can we prevent schizophrenia? How can we treat depression? How can we reduce the negative consequences of eating disorders? And so these are the big kinds of questions that motivated me to get into epidemiology, and the kinds of questions that underlie a lot of the work that I do and my colleagues do across the world. However, a lot of the work, as Janet kind of alluded to already, that I work on is actually also getting into the methods of this. So not just how do we answer these questions, but how do we answer them better? How do we improve the ways that we answer these questions? I didn't want this to be a very mathematical talk, though, so what I'm going to do is kind of go through a little bit more of the philosophy of doing that in a sound manner. And in particular, I want to try to walk us through a couple of steps in this scientific process. So how do we start with one of those really big questions and try to tackle that? And what we want to do is we have to distill it down to some more precise, more manageable, but still quite relevant questions. And once we have a more precise question stated, we can go on to collect and analyze data to obtain some answer to that question, and then discuss the results of that as transparently as we can. Now, the last step, iteration, I just want to underscore is really important here. Science is a process. It's not an end result. I'm not going to talk as much about the iteration part of this, but I just want us to be mindful that this sometimes means going back up to that big question, sometimes refining our sub-questions, sometimes collecting new data, sometimes reanalyzing or reinterpreting the results of that data. And so what I'm going to do is go through this process together with two questions that I've kind of worked with in my research. And the first big question I want to ask is just how many adolescents in the US actually have an eating disorder? How would we try to obtain an estimate for this question? Now, before I go into making that a more precise question, I want to give just a little bit more background on eating disorders for those that are less familiar with them. So traditionally, there were two types of eating disorders that were recognized by medical professionals, anorexia and bulimia nervosa. There's specific criteria that you need to meet in order to get a diagnosis of either of these. I'm not going to go through all the specifics, but essentially anorexia is characterized by this low weight, fear of weight gain, and a disturbance in how one experiences their shape and weight. whereas bulimia is characterized by having binge eating, so overeating with loss of control, and compensatory behaviors such as self-induced vomiting. More recently, there was another eating disorder recognized, binge eating disorder, and then everything else kind of falls under this other category, this catch-all, not otherwise specified diagnosis for eating disorders that don't meet these strict criteria. So one thing to keep in mind is that with eating disorders, the majority of patients that present for care actually fall under this not otherwise specified category. So with that in mind, let's go back to our big question: how many adolescents in the US have an eating disorder? And try to distill it to some more precise, manageable questions. And here I think it's important to think through our motivation for asking that question in the first place. So one possible motivation is that we're trying to get some estimate at how many individuals would benefit from some sort of care. And this is already sort of fuzzy. This is not a precise enough question yet, but this gets at the idea that we might want to know about any eating disorder, or maybe even anyone with a symptom of an eating disorder, and that's the kind of number that we're kind of setting out to get. Another possibility is that we're interested in getting the proportion of individuals with one of the specific subtypes, or a couple of different listed subtypes. So we might want to know how many have anorexia or bulimia, for example. And then finally, another reason we might be motivated for this is that we're trying to understand how to allocate resources for care as it's currently being sought. And in this case, we wouldn't necessarily want to know how many individuals have an eating disorder, but how many seek treatment for it. So when I put these side by side, hopefully it's obvious that they're different questions, and we're going to get different answers to them. And that'd be true if we did this with any other psychiatric disorder. That'd be true if we did this with cancer, or with HIV, or anything else. One of the challenges in psychiatric disorders, though, is that there can be huge differences between these three questions. That's a very different issue between A and B there because of these fuzzy boundaries of what the definitions of our disorders are. And there's a huge difference between B and C because there's a lot of barriers to treatment, like stigma, having a lack of insurance coverage, and so on. And so actually, in work that I've done trying to answer these questions with some of my colleagues, we get very different estimates. We'd say that something like 1 in 10 for the first question, 1 in 100 for the second question, and 1 in 1,000 for the third. So just absolutely enormous differences here. Now again, you might say, of course they're different. I see that they're different. This is, the end of the story here. But part of the process of science is understanding where these numbers get used for the next question we ask. So if we're asking who's at highest risk for an eating disorder, it's important that we know which kind of category we're starting to dissect from. In particular, if we turn to research as it was historically done in eating disorders, most of the research was done in just clinical or specialty care settings. So they were only recruiting patients from these settings who, by definition, were seeking treatment. What this means is that we were really missing the full picture of who is most vulnerable to have an eating disorder. We were missing out on who actually has an eating disorder because we were actually, by definition, looking at who is most likely to seek care for it. And so what I want to do next is just go through some misconceptions that followed from that line of research. And many of these are probably familiar to you when you think of the prototypical eating disorder patient. So first, it's been kind of long thought that eating disorders don't affect males. Indeed, when we look at treatment-seeking samples, it's almost a 10-to-1 ratio. And this is such a predominant belief that's quoted in most medical textbooks. It's quoted in the DSM. And this is really kind of this propagated belief. When we look at some of the community-based samples, however, the ratio of females to males is closer to 2 to 3 to 1. And for some of the specific subtypes, it's actually close to 1 to 1. So yes, they may affect females more generally, but there's such a bigger discrepancy in terms of the treatment-seeking numbers than the community-based numbers. The same could be said for minorities, for looking across Western cultures versus non-Western cultures, looking across socioeconomic status. That when we look at who actually in a community sample meets criteria for an eating disorder, there aren't as big of differences as we get in the treatment-seeking samples. And then finally, based on treatment-seeking samples, we tended to believe that eating disorders onset in late adolescence or early adulthood. This is actually more in line with when they start seeking care, but the symptoms may start occurring many years before. And so this just underscores that we're missing an opportunity to intervene much earlier in the process based on this kind of misinterpretation of the data. Now, another thing to keep in mind when we're trying to refine our question is to think about when we're asking about, in particular when we're thinking about specific eating disorder subtypes. So I know this is a very colorful graph, but just to orient you, each row represents a particular patient who at the beginning of the 12-year follow-up met criteria for one specific eating disorder. And so if we look across just one particular row, every time we see the color change in that row, that means that the diagnosis that we would give to that patient at that moment in time would change. And so if you wanted to get an estimate of how many patients have anorexia in this sample, you'd get very different estimates if you looked at one particular time or if you asked about their entire history or just the past year. And so this is just something we have to be mindful of when we're asking these kinds of questions, is what is the precise question that we're trying to obtain from our data? So then let's go back to our step-by-step. We started with this really big question: how many adolescents have an eating disorder? And one possible way that we could distill this question would be to ask, well, what proportion of US adolescents have ever met criteria for any eating disorder subtype? And then this, again, is just one example. There's lots of other questions that we could have asked as well. But with this question in mind, then we can think about collecting data and analyzing that data judiciously to obtain our best answer to that question. So I worked with the National Comorbidity Survey Adolescent Supplement, which was a survey of about 10,000 US adolescents. And in doing interviews on different eating disorders, we were able to obtain an estimate of about 5% meeting criteria for the subtypes we measured. Now, I say on the slide there that that's sort of a lower bound estimate, and that's because we were very mindful that we couldn't measure all types of subtypes. When we discussed the results, we made clear that we were only getting certain subtypes. We were being very clear about the quality of our measurements and issues with kind of the measurements. But the point is that we were putting it out there as a dialogue to keep on refining. And indeed, since then, there's been a lot of work that I've been a part of where we are able to measure some of the subtypes that we didn't get and try to get better triangulation of these estimates. So now I want to turn to a different kind of big question, a causal question in a sense, which is asking, rather than just trying to count who has an eating disorder, who meets criteria for these different outcomes, we want to do something about it. How could we prevent an eating disorder? How could we treat eating disorders in our populations? How could we reduce the negative consequences of them? And I'm not going to boil this down to one specific sub-question, but I want to give just kind of a feel of the philosophy of this kind of causal inference approach in these settings. So again, we're going to try first to distill this down to a more precise, relevant question. And as we heard in the previous session, ideally we would have our causal questions like this answered with well-conducted, large randomized trials. So if we were interested in looking at like an anti-bullying campaign in schools, we would randomize some schools to receive that campaign, some schools to not, and follow that over time and see if mental health improves in those schools. If we're interested in some treatment for depression, like a new therapy, we'd want to randomize some patients to get it, some patients to get standard of care, follow them over time, and see what is going on. There's a lot of times, though, where our questions are not going to be feasibly or ethically answered with randomized trials. And in fact, for a lot of pressing questions, we also just don't want to necessarily wait for those trials to happen. It might take decades before we really learn the long-term consequences of what happens to a fetus prenatally, just as one example. And so because of this, we have to rely on observational studies. And this comes back again to some of the talks that we heard earlier, where we have to somehow rely on having our causal inferences based on observational data. What this means is that we need to have a way to link our observed data to causal questions. We need some sort of formal mathematical language for saying why our observed data is linked to these questions that we're trying to ask. Now, I don't want to go into the specifics of these different mathematical languages. There's a lot going on there. In fact, maybe that could be an entire Next in Science series, is just all the languages of causal inference. But one of the commonalities that comes out from really thinking about these approaches is that in order to estimate a causal effect, you have to have a precise idea of the definition that you're trying to obtain. You have to know what that starting question was as precisely as you can. Another way to think of this is that you have to have a really good idea of what the protocol is of the hypothetical trial you wish you could have conducted and you're using this observed data for instead. What we see is that if we have ill-defined questions, we end up with ill-defined answers. And so to the extent that we really do want to prevent eating disorders from onsetting or treat them better or improve the lives of the patients who have it, it's really fundamental that we start by making these questions clear. So when we're thinking about this step by step and we're trying to take this big question, distill it down, I think it's really important that we're mindful of how we're distilling this down to manageable but very precise questions. So what is that target trial that we're trying to do? What is the protocol exactly? And then once we've done that, we can think through how we're going to collect and analyze data to answer that question. And that might mean doing something like propensity score matching or regression discontinuity, as we heard earlier. That could be many other kinds of statistical methods. But I think the other thing we need to be mindful of is that these questions or these analyses are always tied back to that question, that there should be a link between the analysis we did and the question that we're trying to ask. And otherwise, we're losing this opportunity where we have counterproductive answers to questions that we haven't actually asked with our studies. So with that in mind, I wanted to just reflect a little bit on the future of epidemiology, or at least some of the themes that I really see kind of set out there by a lot of my colleagues, including bigger data, better data, and then novel uses of some of the newer kinds of data that we have access to. So first, in terms of big data, we heard a little bit about the promises of electronic medical records. We've thought through things like registries. There's a lot of web-based data out there. You can use Google searches to predict flu epidemics. You can use Facebook networks to understand social contagion. There's a lot of app-based data, so if you're wearing a Fitbit, we can, in research settings, use that information to really get an idea of your behaviors. And then some of the newer kinds of data are big just by definition. Genetics and epigenetics and imaging collects huge amounts of data points. So this is all really exciting, and I feel thrilled to be an epidemiologist in an era when these resources exist. But I think we have to be mindful that the big data alone is not why it's exciting. It's exciting because we can tie it to the questions we're trying to ask, and we can find a way to answer those questions using this data. The same kind of thing could be said for better data, that I think we're getting better and better about having more valid measurements, having repeated measurements in individuals, and then certainly getting kinds of measurements that let us peer into human biology in a way that we just weren't able to decades before. As just one example of this, I work with a couple of cohort studies in the Netherlands where we have repeated brain imaging on individuals in our studies. So across childhood development all the way through the elderly, we're able to kind of see how the brains change in these large studies. And this is really exciting, and it really opens these opportunities to understand what healthy aging looks like, how we could prevent cognitive decline, how we could promote better brain development during childhood, and so on. But it's exciting because we can tie that data to these questions. And then finally, some of the newer data allows us to have new uses for this data. And one example that's similar to the quasi-experimental designs we heard about earlier is this idea that our genes could be leveraged as a natural experiment. That, for example, if you started with a question about whether obesity affects mental health outcomes, you could look at obesity-related genes as a proxy for kind of leveraging this natural experiment to try to answer that question. And again, that's really exciting, but these advanced methods, as well as the bigger data and the better data alone, are not going to save us from having imprecise questions. That we need to think through how we're using this to get back to those big questions, back to the more precise versions of them, and really tie it all together. And so what is the future of epidemiology? Well, when I think about these big themes, I think about them all as fitting into this whole process that I was going through. That we're starting with this big question, we're distilling it down to these more manageable questions, collecting and analyzing data, and discussing the results transparently. And so these are offering us huge opportunities to kind of get at this middle step, but we need to be mindful of where it fits in the whole process. So finally, I just wanted to talk a little bit about one of the key roles of epidemiologists here, which is being communicators about all of this. So part of the themes of what I just went through highlight how we communicate our results to fellow epidemiologists and fellow scientists, but we also have to be mindful that this conversation is much bigger than just the scientific community. We want our research to be informing policies at some level. We want healthcare providers, patients, and communities to understand the impact of these findings and use it to inform their decisions. And ultimately, I see that this communication is improved by specifically tying the questions that we want to answer to the way that we answer them. So the way we collect and use data to answer them as directly and best as we can and keep that process going. And so with that, I just want to thank the numerous collaborators that have shaped many of the ideas that I went through here, and thank you all for your attention.
So I would like to thank all of my co-presenters for just beautifully setting up my talk. I really want to give you guys a big hug. Let me know. Okay, there we go. So most of my work is, I'm really interested in how we as epidemiologists can use data to make progress in actually reducing health disparities. I just started at Johns Hopkins, and lo and behold, I found out that a lot of my colleagues are actually developing and evaluating interventions to reduce disparities in healthcare. So, for example, reducing differences in hypertension control between blacks and whites. And a lot of these interventions are based on our current understanding of the epidemiology and about logic models. And so I'm wondering about the sorts of questions that we're asking when we're informing those sorts of interventions and what those interventions should target. So that's really what I'm going to talk to you about today. In my mind, I think of it as work that's helping to extend and further build an epidemiology of health disparities. So before I begin, I think there's some background material that needs to be covered. And what do I mean by a health disparity? It's not just a difference in diseases across groups. The one definition that really resonates with me is one that was put forth by Margaret Whitehead for the World Health Organization, later updated by Paula Braveman, that says that it's a disparity in outcomes across socially defined groups that results through some mechanism of injustice or a process of marginalization. So for example, in the United States, racial and ethnic minorities, because of the history of Jim Crow, slavery, structural racism, segregation, housing policy, interpersonal discrimination, and also lately implicit bias, this have erected significant political and economic barriers which have, number one, predisposed racial and ethnic minorities to higher likelihood of being exposed to environmental toxins, psychological stresses, impeded their ability to lead and engage in healthier lifestyles, and also erected barriers to quality care. Just to make things a little bit more concrete about incorporating this notion of justice into our measurement of a disparity, it's actually useful to look at the way the Institute of Medicine defines a disparity in the receipt of health care. They would define a disparity in the receipt of health care that should capture differences that arise in access to care, or differences that arise in the ability to pay, or differences that arise because perhaps a clinician, in the face of clinical uncertainty, is relying on poor provider-patient communication, or perhaps stereotypes associated with the social group that a patient belongs to. But if there are actual differences in the clinical need between the populations, and there were differences because of that, that's not something that would contribute to a disparity. So for example, in the same psychiatric epidemiology studies that Sonja was talking about, you see a 60% lower prevalence of major depression for blacks. And so if you see disparities in treatment, that may not necessarily constitute a disparity. You would want to estimate disparities in antidepressant use among those who have a clinical need for antidepressants. So it's clear that our measures of disparity should be capturing processes that involve marginalization and also injustice. So in thinking of an epidemiology of health disparities, I think it's also good to go back to the basics, even though this has been a central theme throughout the day. We're essentially charged with of understanding how diseases are distributed in the population. And one of the major hallmarks of epidemiology has been to identify what are the causal factors that are actually influencing disease, with the ultimate goal that we develop interventions to improve population health. This is a conceptual model by the late Brian McMahon, who first chaired the Department of Epidemiology at the Harvard T.H. Chan School of Public Health. In this model, it reflects the current thinking at the time, where chronic diseases, it was realized that chronic diseases weren't just caused by a single agent, but actually a constellation of factors. And a key insight of his was that it's not necessary to map out the entire causal structure of a disease or how all of these factors coordinate and orchestrate to cause disease, but rather it's important to identify the particularly salient causes that intervening on them we could reduce a substantial amount of disease and morbidity in the population. Now this aspect of multi-causation has been discussed quite a bit today. It's been a thorn in the side of many epidemiologists because these causes are correlated with each other. And so in the absence of a randomized trial, say if I was going to look at the effect of eating a healthier diet and whether I could control my hypertension, well, it might be that patients like me also live in neighborhoods that are food deserts and don't have opportunities to buy healthier foods. But the streets may not be safe to exercise on. There may not be facilities where I can go and exercise. And so you have this correlation between being able to eat a nutritious meal and also exercise regularly. And so without going into it, we've heard about this today, but I spent the last 5 to 8 years of my life learning how to tease out this association between causes to try to map towards a randomized trial. Some of that involves tools like propensity score matching, regression discontinuity, statistical adjustment. This is a figure showing the life expectancy in the United States from 1975 to 2003 for blacks and whites segregated by sex. What you see here is you see that for all groups, you see an improvement in life expectancy by at least 6 to 8 years. But you also see that the racial difference in life expectancy over that period has persisted for both males and females. And so the implication of this figure to me is that simply understanding and intervening on the determinants of health or determinants of disease may improve population health, but it may not necessarily translate into the reduction of disparities. One of the major thinkers of health disparities and their genesis is Sherman James. He was the pioneer of studying health disparities. And what in this model, what I particularly like is that he's linking determinants of disease to disparities in outcomes. And he's shown this in a very comprehensive way. So you see determinants of disease organized as environmental factors, also as behavioral factors, issues in quality and healthcare. Now in the text, you can't really see this in the figure, but in the text, what he goes on to say is it's actually the disparities in these determinants of the outcome that are driving disparities in these outcomes. So for example, disparities in incidence, he's arguing, as you can see by the weight of this arrow, are driven largely by disparities in the environment, in air and housing quality, and in social relationships, experiencing discrimination, living in areas where there's high concentrations of poverty. Disparities in prognosis, though, are driven more by disparities in the access to and the utilization of healthcare. whereas the disparities in mortality are driven more by prognosis and also disparities in care. With the acknowledgement that all of these disparities and these causal factors are shaped by larger political and economic structures. Now, in thinking of designing an intervention, if we had a particular outcome in mind, well, we could target so many different disparities here. So how do we actually choose? How do we do that? And there are numerous things that we have to consider and trade off. For example, how much will it cost? Is it feasible? Do we have a window of opportunity? Do we have the political will? Do we think that these interventions are sustainable? But I think the key ingredient to all of this is solid evidence that intervening to remove disparities in a particular target, that we're pretty confident that it will result in reducing disparities in the outcome. And so I would call that sort of effectiveness. So how do we actually use data to sort of understand how removing disparities in a target will actually lead to a reduction in disparities of outcomes? Without going into the specifics of this today, I would say that most of what we do today is to quantify how disparities in a particular target statistically explain disparities in outcomes. The problem is that most of these approaches are not explicitly accounting for potential confounding factors of those targets. And so we're not ruling out alternate explanations of why those disparities in those targets may statistically explain disparities in outcomes. So if you think back to that graph I showed you about diet and nutrition, there are these other confounding factors. And it's really what I'm going to talk to you about today is how we can improve these methods to incorporate explicit assumptions about confounding control. And I'm going to do that by walking through a very, what I hope is an easy to digest example analysis. I'm going to reuse data from a seminal paper by Roland Fryer, who's actually a renowned economist here at Harvard University, who showed that if you look at the association between race and some key outcomes, including race, incarceration, and unemployment, if you adjust for educational attainment, you see that those disparities reduce substantially. And in the case of health, you see that the disparity actually vanishes. And so essentially, what the data show is that disparities in educational attainment or test scores statistically explain disparities in wages, disparities in incarceration, and disparities in health. But there are alternate explanations we could consider. For example, it may be that disparities in educational attainment are merely a reflection of disparities in childhood socioeconomic conditions. And so it begs the question, will we see those same results if we repeat the analyses to actually control for childhood socioeconomic conditions? Another question is, well, maybe the attractive target could be test scores, but maybe the target could be to actually remove disparities in childhood socioeconomic conditions. It's another question we could ask. A third question is, well, what if we could remove disparities in both childhood socioeconomic conditions and test scores? And so what I would like to do is just to walk through a couple example questions in this data, incorporating, again, clear assumptions about confounding. And even though the methods are going to be really pretty accessible and pretty simple, they do draw on a power counterfactual framework that does map to a hypothetical trial, which allows you to really say if you believe that you've measured and adjusted for all the appropriate confounders, that you can interpret it as an intervention effect. And so really what you're asking is if we could intervene to equalize these risk factors, if we could intervene to remove disparities in this target, how would that impact disparities in the outcome? And so I'm going to run through four analyses. One, I'm going to ask what's going to happen to the disparities in wages, incarceration, and in health if we could remove disparities in childhood socioeconomic conditions. Then I'm going to ask what would happen to disparities in our outcomes if among those with the same childhood socioeconomic status we could remove disparities in educational attainment as reflected in test scores. And again, I'm changing the population here because I want to rule out differences in childhood socioeconomic status. I want to account for confounding. The third one is, what if we could intervene jointly to remove disparities in childhood socioeconomic status and test scores? And the last one is really, what if we could remove disparities overall, irrespective of childhood socioeconomic status, which may be something that we're more interested in. Considering our first intervention to remove disparities in childhood socioeconomic status, under some pretty strong assumptions, and in this simplified example, we could estimate this by fitting a model for our outcome, given race and the covariates age, gender, and ethnicity. And the race coefficient in that model would simply describe the disparity in the population as we observe it for people of the same age, gender, and ethnicity. Now, if we refit that model and we include a term for childhood socioeconomic conditions, again, under some strong assumptions, we would interpret that as the remaining disparity in our outcomes after an intervention to remove disparities in childhood socioeconomic status. The key assumption here is that we've adjusted for all the confounders of childhood socioeconomic status, and we've heard a lot about that. Those are usually pre-treatment variables that are also determinants of whatever outcomes that you're studying. So conceptually, what does this really mean? So to help us sort of sort through this, I created some figures. So on this top line here, you see the distributions of childhood socioeconomic conditions, educational attainment as measured by test scores, and the distributions of our outcome. And on the bottom, we have the counterfactual distributions. This is for blacks and then for whites. So we have the counterfactual distributions. And so what the yellow arrow represents is the effect of our intervention to actively remove disparities in childhood socioeconomic conditions, namely to shift the distribution of childhood socioeconomic conditions such that they align with the distribution of childhood socioeconomic conditions for whites. The faint dotted arrow represents the propagation of this effect to reduce disparities in test scores and also reduce disparities in our outcomes finally. So that was our first intervention to remove disparities in childhood socioeconomic conditions. Our second intervention is to remove disparities in our outcomes among those of the same childhood socioeconomic conditions, and by removing disparities in educational attainment as reflected in test scores. So again, under some pretty strong assumptions, we could estimate this by fitting a model for our outcome, given race, the covariates, age, gender, and ethnicity, but we also want to include in this initial model childhood socioeconomic conditions because we want to account for confounding. So again, now the race coefficient in that model is going to give us our observed disparity among people who share the same socioeconomic status in childhood. Now we're going to add to that model a term for test scores. And what this, in the race coefficient in this new model would equal, again, under some strong assumptions, what the disparity we would observe after an intervention to remove disparities in test scores among those who have the same childhood socioeconomic status. Again, this is under an assumption that we've measured all the confounders of test scores and adjusted for them. So heuristically, what's going on here is I'm showing you the distributions of childhood socioeconomic conditions, and then I'm showing you the black and white distributions for test scores among those with low socioeconomic status and among those with high socioeconomic status, and then also for the outcomes. Again, conditional on childhood socioeconomic status. And on the bottom line, we have our counterfactual disparities. So the intervention doesn't touch socioeconomic status at all, but rather it's within levels or among those who share the same childhood socioeconomic status. So there's some details I put into this figure that I want to point out. The first detail is that for those with lower childhood socioeconomic status, it's plausible, highly plausible that the distribution of test scores for both blacks and whites is actually lower than the population average. And then, again, for those with high childhood socioeconomic conditions, their distributions are going to be higher. The implication of this is that when we do our intervention to shift the distribution of the black distribution to where the white distribution is, for those with low socioeconomic status, we're not going to move it that far. But this is problematic because this is where blacks are overrepresented. And so our intervention to reduce disparities in educational attainment among those with the same childhood socioeconomic status is probably not going to achieve as much as we would like it to. But yet, this is the very analysis, this is the principled analysis that we have to do because we want to account for confounding my childhood socioeconomic status. So our third intervention is to look at what could happen if we could intervene to reduce disparities in both childhood socioeconomic conditions and also educational attainment as reflected in test scores. So as similar to before, we're going to start with a model for our outcome given race and the covariates. Initial race coefficient is the disparity we observe in the population. If we add in terms for childhood socioeconomic status and also test scores, the new race coefficient is going to, we could interpret that as the residual disparity we would see under an intervention to jointly remove disparities in childhood socioeconomic status and also test scores. Here we have a stronger confounding assumptions that we need to meet. We need to ensure that there's no unmeasured confounding for childhood socioeconomic status and also no unmeasured confounding for test scores. So this is a stronger assumption than we need than we used for our other analyses. So heuristically, these are our observed distributions for childhood socioeconomic status, test scores, and outcome. And you can see our intervention is to shift the distributions of childhood socioeconomic status and test scores for blacks to their respective distributions among whites and observe some reduction in the disparity in the outcomes. So I've described to you so far 3 interventions. The first intervention would be to reduce disparities in childhood socioeconomic status. The second one is where we wanted to look at the impact of removing disparities in test scores, but we had to do it among a special group of people who share the same childhood socioeconomic status because we wanted to control for confounding. And this third one was we said, well, let's just try to intervene on both. But really, an intervention that we might think about is, well, what if we could just remove disparities in test scores without even looking at childhood socioeconomic conditions, but account for the confounding there? That's the real trick. That's the real tough one there. And we're interested in doing this because it may be more feasible to remove disparities in educational attainment than to remove disparities in childhood socioeconomic conditions. So without getting into too much of the math, it turns out to estimate this, to answer this sort of question, we can't rely on the typical subtraction of race coefficients. And the reason why is that an intervention to remove disparities in test scores overall is going to partially block the effects of disparities in childhood socioeconomic conditions. And so without so if we think of it another way, the effect of childhood socioeconomic status on our outcomes is partially mediated by test scores. So if we intervene, we're going to block part of the effect of disparities in childhood socioeconomic conditions. And in English, the way that this is estimated in these linear models is simply to first start with the disparity reduction upon equalizing test scores among those with the same childhood socioeconomic status. That was our second intervention. Then we're going to add to that how much the disparity would be reduced under removing disparities in childhood socioeconomic status. That was our first intervention. But we're not going to add all of that back in. We're only going to add in the amount by which the effect of childhood socioeconomic status is not, is mediated by test scores. And so heuristically, all we're doing here is intervening to shift the entire distribution of test scores among blacks to where whites is, but we're not doing anything to the distribution of childhood socioeconomic conditions. So in our reanalysis of the data, what do we see? Well, we see, as we would expect, that the most effective intervention is to remove disparities in both childhood socioeconomic conditions and also test scores. So it removes 74% of the disparities in wages, 81% of disparities in incarceration, and completely eliminates all of the disparities in health. What's fascinating, though, is that if we just were to remove disparities in educational attainment alone as measured in test scores, it's not that far behind. We could remove 2/3 of the disparities in wages, 2/3 of the disparities in incarceration, and once you account for the standard errors, all of the disparity in health. What's also interesting is that it's as effective or more effective than intervening to reduce disparities in childhood socioeconomic conditions. And so just looking at disparities in wages here, if we removed disparities in childhood socioeconomic conditions, we remove about 1/4 of the disparity. But if we were to intervene to remove disparities in educational attainment as reflected in test scores, we would remove 2/3 of the disparity. And finally, our intervention where we were going to remove disparities among those who have the same socioeconomic status removes 65% of the disparity among those who have the same socioeconomic status, but it bears pointing out that this is a less ambitious goal because the initial disparity is smaller. And so if you just look at the difference between where you start and where you end up, you can see that it's a less effective intervention. Also, the nature of what we mean by educational attainment is important, which gets back to Sonja's point about what question are we asking. If we were to try to equalize total years of education, we see that the disparity is actually as effective as equalizing childhood socioeconomic status, or in some cases less effective. So there are some limitations. We used really simple models and work with Tyler Vanderweer, which this is based on. We've extended these to more general outcomes, nonlinear outcomes. We have non-parametric formulae that can incorporate interactions, account for confounders that are descendants of race or whatever social status that you're using. In future work, we hope to extend these out to longitudinal outcomes, including repeated measures and time to event outcomes. And also in other work, it's of great interest today. You hear a lot of people talking about intersectionality. So people are not just marginalized in one way. They may be marginalized because of their socioeconomic position and also their race. In other work, I've talked about the notion of joint disparities and also intersectional disparities. And it is definitely possible to map these sorts of analyses to disparities along multiple axes. The implications of our study, though, what we found is we actually confirmed the results of Fryer, but we've added important information. Number one, we've ruled out disparities in childhood socioeconomic status as an alternate explanation. It really does look like disparities in educational attainment as reflected in test scores is really the important target here. So what are the implications for the next steps in health disparities research? And I think Sonja stole my thunder here, but what I would like to say is that we have a real opportunity here to do these sorts of analyses very carefully. And this was a toy example here, but when we actually have cohort data or exquisite medical records, we can actually look at what is the thing that we're trying to intervene to reduce disparities in. For example, if we're looking at adherence, or if we're looking at nutrition, or if we're looking at whatever target that we're interested in, we should think about what are the confounders of that target. And then we should also try to ensure that we have longitudinal data. We should also try to ensure that we respect the temporality of our confounders and our targets and our outcomes, just like we do in careful and rigorous epidemiologic studies. We have a real opportunity to do this. Now, all this talk about confounding, the big elephant in the room is unmeasured confounding, which our first speaker eloquently pointed out that sometimes you have these variables measured, but many times they're not measured. But what I would argue is that an epidemiology of health disparities is actually in a better position than a de novo study in epidemiology. And the reason is because usually health disparities analyses are built on existing knowledge about epidemiology. So for example, if we're just starting out where we're trying to identify how disease is distributed in the population, well, that's the step where we're actually describing disparities in disease. When epidemiology is doing the hard work of trying to identify the causal factors, teasing out what are the other risk factors, are we doing the best adjustments for confounding? This is really where the field of disparities would still be determining what are the disparities in those determinants that are being identified by those epidemiologic studies. When we go on to design strategies to improve population health, part of that we're thinking about, well, how can we actually reduce these disparities? But we have all this knowledge that we've gleaned from these epidemiologic studies. So when I would go and pull these medical records and think about what are the variables that I need to adjust for, well, for disease areas like cardiovascular disease, we know what the major risk factors are. We know what needs to be adjusted for. And even if our cohorts don't have them, it at least gives us a clear list of things that need to be measured in whatever cohorts or synthetic cohorts that we're designing. And so I'd argue that, yes, the confounding structures are something to be concerned about, but we're in a much better position when trying to do these sorts of analyses that I'm describing here. And hopefully, these sorts of robust analyses are what's going to be used to build conceptual models for designing interventions. Another implication of the work that I'm presenting here is that how we define a disparity matters exquisitely for its explanation. As I said before, a disparity measure, particularly when it comes to treatment of care, would condition on certain things and not others, right? So in the case of disparities in antidepressant treatment, we would condition on clinical need. If we went on to condition on access to care, we're going to miss some of the disparities among people who aren't able to access treatment. And so what that means is when we have our covariates that need to be adjusted for, we have a choice. So we can condition on things like age and family history and gender and prognostic score, and we can adjust for them that way through conditioning. But for all of the other things that are sort of tied to injustice, like socioeconomic status, health literacy, and insurance, where you live, we don't have to adjust on those things. I mean, we don't have to condition on those things. We can adjust for them without changing our disparity measure, which is important. And so really it's the hope that with these sorts of careful, principled analyses that we can develop refined conceptual models that will help us provide better estimates of how effective it might be to intervene on one particular target versus another. Thank you for listening, and I welcome your questions.
Thank you both. Those are really terrific talks. I learned a bunch of stuff from them. So we'll open up for questions, and maybe if anybody's got a burning one, you can start, but if not, I will ask a couple of mine. So Sonja, so partly because I'm fascinated by these studies, could you talk a little bit, you flashed up the picture of the cell phone study. Mm-hmm. Could you tell folks a little bit about those kinds of studies and what you're doing and
Sure,
how those work? I think it's a really interesting example of better data.
Sure,
yeah.
And I'm happy to hear that you have some experience with it as well.
Barely.
Yeah, so one of the main starting points in this cohort study I mentioned, based in Rotterdam that I work with, is we're starting to have these kind of app-based studies where we give participants in our studies sort of these prompts on their cell phone to answer certain questions over time. And so just thinking about something like eating disorders, if you're trying to understand sort of what causes someone to engage in a compensatory behavior today, and you're trying to understand that behavior today, you want the context of what happened on that day. And so these app-based kind of things allow you to get kind of real-time collection of that data rather than asking a survey every 2 or 3 years or something like that. And so I think there's a lot of opportunities to kind of refine your questions to kind of ideas of what's happening at the hourly limit or the daily limit or things like that with these kinds of studies.
Yeah, so some of the things you can, we're doing a study sort of similar to that, also looking at some eating behaviors. You can look at perhaps what was the potential emotional trigger that day, or you can use GPS data, with obviously with everybody's permission to use it, and see were they walking by a Dunkin' Donuts? You can really get down to a very fine-grained level. I see Bert's got a question too, specific to this one. Yeah.
First, 2 great talks. Thank you very much. I have a question. A question for Sonja. You say, I would like to basically do a trial to study efficacy, but I can't very often. So let's design a study to mimic then the trial. So that is what you want to do a good study. And you also say, I would like to refine the question in such a way that I have a meaningful answer to a good question. Now, very often, in the past, 5 to 10 years, clinical trials are being criticized for being not relevant in terms of the question they address. This tension between what you want from a design viewpoint and from a relevance viewpoint. Can you discuss that a bit?
Sure. So I'll just take one of the criticisms I know for trials, which is that they often are kind of focused on really select patient populations. So, just kind of to stick with the eating disorder example, if you want them to meet exactly the criteria for anorexia nervosa and you want to rule out kind of comorbidities and things like that, you might really restrict the ages, you might really restrict it to females and so on. And so you might get a really good estimate in that population in that trial, but it doesn't generalize to larger populations. What I would argue is actually in observational studies, you have this opportunity to make it exactly the population you care about. So like when we have electronic medical records or we have big data opportunities, if we think about the population we want to ask the question for, we can make it more relevant and tie it to that population. So I see it sort of as maybe not the trial that we would have conducted, but the trial we really wish we could have conducted is what you're trying to emulate. Yeah.
I've got a question for John. This is sort of in the fantasy baseball camp kind of realm. You talked about those unmeasured confounders. And I think very often when we're talking about social disparities, there's a lot of elephants in the room and a lot of unmeasured confounders. And I think my question for you would be, you had for that analysis, you had the National Longitudinal Survey of Youth, which is actually a pretty detailed data set. What would you ideally want to answer the question? First of all, what are the particular questions that are most pressing to you? And then to get at those, what are some of the pieces of data you'd really love to have?
Well, I think, so one area that I'm actually starting to work in is in hypertension control. So I'm really interested in lifestyle behaviors and versus disparities in adherence. I think what I tried to stress in the talk was that it's not really that you need the confounders to be balanced across racial groups. You need them to be balanced across exposure groups within racial groups. Mm-hmm. So it's actually the same assumption that we use in our standard epidemiologic cohort analyses. It's no different. It's the same thing. So, in terms of those, I really just want to make sure that the major risk factors for cardiovascular disease are actually measured well among both groups. I think the challenge is finding cohorts or follow-up studies where you have adequate data on all social groups that you're interested in. I think that's the challenge.
Yeah. Yeah.
Hi, I have a question for Dr. Jackson as well. So with unmeasured confounding and everything like that, and I kept thinking about the first example you gave about depression and like clinical need, or I guess like every disparity that you see doesn't necessarily mean like a difference in people getting what they need, essentially, when it comes between blacks and whites. But I guess I would push on that because when it comes, isn't that still like a symptom of disparities in, say, like healthcare? So just because there's a higher prevalence in, say, depression among, or at least clinical depression among whites, does that still mean that there can still potentially be the same level of prevalence of depression in blacks, or even more so, but it's because of stigma and mental health in the community and things like that, and also barriers to healthcare? That's like another unmeasured thing we're not looking at. So even if you do condition on it in your analysis, it doesn't necessarily account for it.
Well, there's a lot there. I think in the psych epi literature, you see a couple things. Like you see a lower prevalence of both current and lifetime depression among blacks, but you see worse prognosis. So you see you see a higher prevalence of recurrent depression and also chronic forms of depression, and you see poor functioning. So I think if you're thinking about clinical, once you condition on clinical need, I'm not sure that you're missing disparities in treatment. If you're talking about people who are showing up initially on a first episode, or if it's a recurrent episode. I'm not sure if I'm answering your
question adequately, but I'm not sure how you would be missing the disparity by really. So if you're thinking about a disparate treatment, you're saying that people who need the medication are getting it less often than someone who's, in all other instances, clinically like them, but of a different race. And the key issue is that they both need the medication. Whether or not, there's a lot of debate about our estimates in the psychiatric epidemiology studies. Is it because of selection bias? There's large chunks of the African American population missing from household surveys. Is it because of differences in how people are answering the tools that we use to measure depression? Is it because of differences in reporting to somatic symptoms versus more psychological symptoms? But none of those alternate explanations have been compelling, at least up to this point. So most people believe estimates that the prevalence of major depression is in fact lower among African Americans. So really, the disparities in treatment should really be conditional on clinical need.
Sonja, something that you put up during your talk really resonated with me, and that's the notion of epidemiologists communicating with non-epidemiologists, which is the focus of this session here. And I'd love for both of you to reflect on that, because I felt like in my training, I wasn't trained on how to do that. I can write a scientific article like nobody's business, but I can't communicate with the public, and yet so many of our public health messages are known. Like, people know wear a condom, people know get vaccinated, and our approach, my impression of our approach has just been to lambast the public with more and more data. But so is it a function of our training? Like, how do you think we can go about doing a better job of this?
This is a tough one. I think, I don't know, part of it's a challenge of just the history of how we've conducted the science, and that, I think earlier on we were really getting at just pure associations, and so we've really trained the public to view a risk factor as sort of being associated with a disease, but maybe not necessarily thinking through in terms of gradations about the particular type of question that we're asking. So it's, for instance, duration of exposure to a particular risk factor or among a certain subgroup. I'm not sure I actually have an answer for that. I mean, part of it has to do with the state of our science when it goes out to the public, and how much control we have over that to actually build in qualifiers. I'm not sure I have, to be honest, I just don't have a good, it's a problem, I think, in that we have a lot of over-interpretation of our scientific results. I think most people, when you explain the limitations of epidemiology in terms of trying to make fair comparisons, most people really do understand that. But in terms of communicating a really finely detailed, granular answers to questions, I'm not sure that we're really there yet.
Yeah, I'd probably echo some of that. I think of, certainly like when I talk to my parents or non-epidemiologists in my friendship or family circles, everyone is very trained to know that correlation is not causation, right? And that's like, we get that from a high school statistics course or middle school science class. And what I think that's built is sort of this level of skepticism where you can just kind of pick the studies you want to believe if they support your kind of beliefs about the world. I think maybe something that epidemiologists could do better is try to train people to think through how, if our question really is causal, if I'm trying to decide, should I take that treatment or should I recommend this change in the schools or change in, my hospital policies or whatever it might be, how can I support that empirically, and how can I understand really what the assumptions are underlying that empirical estimate? I'm not sure if that can happen, in high schools. I don't know if that's just when we convey our studies to really be transparent about all the assumptions upon which they rest, because maybe that just makes more skeptics about it because they are strong assumptions. But yeah, I think that that's probably where I would start, is just trying to revisit that when our question is causal, we should be explicit that that's the question, and then how confident we are in those answers. Yeah.
If I could add one more thing, I think what would be, in addition to what Sonja talked about, would be really helpful is perhaps as epidemiologists, instead of saying what the question has answered, maybe list out what it hasn't answered. So for a lot of medications, we don't have data on long-term use. So for psychotropics, what's the actual effectiveness 5 years out, 6 years out, 10 years out? Do we actually have good data on that? Because I think a lot of times when we're thinking about these risk factors or things that we encounter, there are certain assumptions that we make about how we're using them and what the risks are without any data to support that. And so I think pointing out perhaps what the questions are that aren't being answered. If we list those out along with the question that we did answer, it would probably help sort of frame what we know and what we don't know.
Maybe just one other thing I would add, just thinking about this more, is among epidemiologists, I think we're good at doing sensitivity analyses to try to understand how robust our conclusions are, but that could be communicated better as well, right? That there's a lot of times that we show something and we say there's an effect, and then that makes some New York Times headline, and it gets kind of lost in the noise of how confident we are in that. But I mean, we're confident that vaccines save lives. We're confident that vaccines do not cause autism, that smoking causes lung cancer, that safe storage practices of guns saves lives. Like we know those things, and we know those things because we've done a lot of sensitivity analyses. And I wonder if there's a way to kind of communicate that better too.
Thank you both. I think just kind of piggybacking on the conversation about communicating results, and also specifically, John, you invoked this kind of third part of the definition of epidemiology. It's not just describing the distribution of determinants, it's using that knowledge to apply to improve the health. So a question specifically for you, John, and then for both of you, kind of what is our role in the context of your findings with test scores? It's easy to now have this take-home message after that complicated methodologic kind of decomposition of the effect to point to that. But obviously, that's also multifactorial, what goes into test scores. And that's still kind of a proxy for many other things that also intersect with many different planes of our experience. But just can you guys both speak to kind of what our role is as epidemiologists in that next step of moving things forward, or if you have ideas of kind of what that could look like within your specific research.
Yeah, so in terms of being a methodologist, I'm not an expert in education by any means, but in terms of like where I see the work that I'm doing methodologically is really a first step. I haven't said anything about how you're going to go about reducing disparities, but if you know exactly sort of what the bound is of like what you could achieve, then you can actually start to think about how can I design observational studies to actually get at more detailed interventions that I could perhaps map out. So if you designed a target trial to say, if we intervened on these two social groups in particular ways, what would the reduction in the disparity be, and have very explicit intervention strategies. And that, so it's sort of I see as a winnowing down. So all these targets, and then given sort of an upper bound of what we could achieve by removing disparities, then we can actually get to finer intervention strategies. Along the way, I think it's important to also leverage actual policy changes and actual interventions and natural experiments to actually see what real interventions have accomplished. And so I sort of take these sorts of analyses as sort of guiding our focus about what to sort of do follow-up studies on. And at the end of the day, it's going to take real experiments to actually get robust evidence for this.
Yeah, I'm not sure I can add anything better to what you just said, so I won't even try.
Hi, I have multiple questions, but I'll limit it to one. Well, actually, maybe two. First, I was very interested in the disparity in general for black males versus white males that are going on, and saying not that black males life expectancy is going up, but the white males is going down. You know, the big issue that's being made about that. One of the things that I'm really interested in when you mentioned about test scores in education, recently Mrs. Obama was shocked that they want to roll back the standards for the food, the quality of food that students have, which is contributing to the brain, which contributes to test scores. And I don't know if there's an opportunity for you to, not you personally, but you in the general, to speak about the the correlation between being fed well and being able to perform to get to a higher socioeconomic status.
I think there's been a lot of research that shows that providing lunch and food programs actually improve outcomes in education. But you know, one thing that I think there is an opportunity to sort of use this to look at the data of the effect of this policy change on outcomes for both whites and blacks across different sectors of the nation. That's a first step of something that we could do.
Was there a second question? Oh, I forgot another.
Thank you very much. I was very struck, especially Sonja, but on all four of your presentations today about how accessible it was to non-epidemiologists. And I guess I wanted to go back to the communications kind of theme that has been talked about a little bit. In so much as, do you see that there are natural partners or people in the public that you should look at as advocates or develop different types of partnerships so that the messages that you're bringing out can be more effectively delivered?
That's a great question. So without having thought about it before you asked that question, at least off the top of my head, I would say certainly there's a lot of opportunities to work with more nonprofit organizations or maybe like the heads of hospitals if your research are kind of targeting how we deliver treatment or something like that. I'd say the other big partnership that I see is just the media. The media is not necessarily that great at reporting on scientific findings because there's this balance of you don't want sensationalism, you don't actually want media to be all about one study. As I tried to emphasize, it's about this whole process and about kind of continuing a conversation about where we are with the science. But maybe that'd be a place to start, that if you get newspaper articles or TV coverage of these studies to be kind of better articulated in the context of where they're coming from, that might propagate further into the communities more. I don't know if you have other thoughts.
I don't have too many other thoughts. I think it's important to sort of partner with the end users of your research. And so I think getting them on board early on helps you ask better questions that are more informed. So I'm primarily, work in methods, and so I have to partner with clinicians and hospital administrators to see exactly what are the types of interventions that they're interested in and how can the analyses that I'm doing actually inform it. And if they're there at the ground level, then I have an opportunity to also educate them about what's possible with these results and what they mean, what they answer, and also what they don't answer. I think sometimes things can fall short when you do your analyses in a vacuum and then take them to a stakeholder or a user and sort of try to explain all the intricacies of what you're doing. It could be problematic.
Yeah. Maybe just to go with that a little bit more, I could see too the kind of using a paradigm that I was walking through with the step-by-step to get the end users more to help with the precise questions at the beginning too, so that they're actually engaging in the whole process with you.
This is a question for all four of our presenters. We've talked about the conclusions that epidemiology can reach, the importance that these conclusions have on policy, and the importance of communicating properly to be able to affect policy. Communication, however, also depends on the receptivity of your audience. And we have a great difference in the audiences that you're addressing. Our first presenter is addressing a audience which is very receptive in general to the ideas. Our last presenter is addressing the current political power structure, which is not going to be receptive necessarily to these ideas. How do the four of you, in both your collective realms and your individual specialized realms, deal with these difficulties of communicating effectively and productively?
Great question. I'll start. First, I really want to thank you for that question. It's a challenge because you have to master so many things, not just the methods, the statistics, but also the history, the policies, and there are a lot of things that areas where you can learn more. I think for me, that's a really tough question of communicating effectively. I think part of it is learning that I can't really do this alone, and sort of partnering with other people who are doing this work, who are also doing this on the ground level, partnering with people who are engaged in the community, people who are actually developing policy, and maybe that's an opportunity for me to sort of understand how to frame my analyses in a way that's both clear and also effective. I think the subtext to your question is the weight on facts today, especially facts that you don't agree with. It's a lot harder now to come with and to come and present data, especially when it challenges someone's preconceived notions. I'm not sure I have the best answer for that at this moment. I think what I've decided to do is to try to do the best science that I can do. If someone's mind is not amenable or open to data, there's not really much that I can do, but I can be persuasive to people around them, or I can also be persuasive to things on other dimensions, such as costs or other things that they might care about.
Yeah, I guess I might add some of my heroes in epidemiology work in firearm safety and looking at how we can save lives by storing guns safer, treating them safer, things like that. Obviously a very hot political topic. I think some of the successes that I see in how they engage in the science there is first just acknowledging that they're doing these scientific estimates, that they're not giving a moral argument to it. They're not part of the larger questions of liberties versus safeties and all of that. They're just trying to give these estimates of how many lives could be saved or how many injuries could be prevented, and trying to do that. And then I think that when they communicate that, they really look for people in the communities that can start having that conversation and propagating the conversation a little more. So focusing on parents of kids, because everybody wants our kids to be safe, or focusing on the instructors of gun safety courses. And I think that that's maybe how you do it, is it's an incremental conversation that you have, but recognizing that you're doing the best science you can do, and that's part of a larger story of how we function as communities, yeah.
I was working with myself and my colleagues who work in resource-limited settings. So in South Africa, we work with the South African government quite a bit. So what has required us to actually build that relationship well is listening to them, and not going in there as a foreigner and forcing whatever we've believed to be whether an association or something that's causal on them. So it is really listening and having a conversation. And like you said, Sonja is doing it incrementally, and not overloading people with information, because it doesn't help. But it took a long time for us to develop these relationships with the South African government and people specifically in there who will help to actually have an effect on policy. It's that conversation that's been over the last probably decade that has helped us really kind of communicate effectively and change policy at that level. But, yeah.
Yeah, I have a couple of thoughts. I don't have anything additional to what's already been shared. I agree with that. At the hospital where I work, the IRB has community members that sit on it, as well as studies that we enroll. We usually try to have community representation to ensure that it's asking a question that people actually care about and that it's represented accurately. And just a anecdote from my own work. Before I was doing this, my dissertation was on vaccination and vaccine-preventable diseases. And naive me thought that everyone would just get vaccinated once they saw this science, right? How can you argue against that? No, I am no longer naive to that. And so one thing I think we can do a better job, and I started to do this, was let's reach out to the anti-vaccination community rather than just scoff at them. So I engaged one of the representatives and said, all right, what do you propose? What do you want to have happen? If you are so adamant about not getting vaccinated, what's your proposal? Because one thing we can all agree on is that we don't want otherwise preventable diseases from making a resurgence as they're doing now. So what are your alternatives? There's really an enlightening conversation that I had with this person, and I actually wanted to write this up and publish it, and just like a magazine, unfortunately I didn't get permission from them, but it was still, I think that's something that we can do, is just reach out and ensure that we have a balanced viewpoint on things that we're not just, because it's in some ways it is kind of insular in the community that I work in, like everyone kind of thinks alike in the public health program. We all believe that these are the interventions that people should have, but it's really interesting when you kind of get outside of that and talk to other people that have just as strong and are very eloquent speakers as well, opinions to the contrary. It's helpful to kind of humble your work in a way as well. So I think that's, to me at least, like having community representation and having a dialogue with people that are just outside of your direct role.
Well, thank you all very much. We've got a reception outside, so please first join me in thanking actually all four of our speakers.